Good afternoon to all of you. Myself Anil Mina, nursing tutor, Index Nursing College, Indore. Today we will discuss about ARDS, Adult Respiratory Distress Syndrome. Introduction. Adult Respiratory Distress Syndrome, recently known as Acute Respiratory Distress Syndrome, is a severe form of acute lung injury. The clinical syndromes is characterized by a sudden and progressive pulmonary edema, increased bilateral infiltrates, infiltrates on chest X-ray, hypoxemia, refractory to oxygen supplementation, and reduced lung compliance. These signs occur in the absence of left-sided heart failure. Patients with ARDS usually require mechanical ventilation with a higher than normal airway pressure. Definition. Adult respiratory distress syndrome is a severe form of acute lung injury which occur as a result of an intra-inflammatory trigger that initiates the release of cellular and chemical mediators, causing injury to the alveolar capillary membrane. This leads to leakage of fluid into the alveolar intestinal space and ulceration in the capillary bed. Etiology: aspiration, gastric secretion, drowning, drug ingestion and overdose, hematologic disorder, disseminated intravascular coagulopathy, massive transfusion, cardiopulmonary bypass, prolonged inhalation of high concentration of oxygen, smoke or corrosive substance, localized infections, bacterial, fungal, viral pneumonia, metabolic disorder, pancreatitis, uremia, shock, any cause, trauma, pulmonary contusion, multiple fracture, head injury, major surgery, fat or air embolism, systemic sepsis. Pathophysiology: alveoli, right main stem bronchus, right lobes, trachea, left lobe, pleural fruit, diaphragm. Pathophysiology: Pathophysiology and inflammatory triggers that initiates the release of cellular and chemical mediators causing injury to the alveolar capillary membrane, leads to leakage of fluid into the alveolar intestinal space and alteration in the capillary bed. Severe ventilation perfusion mismatching occur. Alveoli collapse because of the inflammatory infiltrate blood from blood fluid and surfactant dysfunction. Small airways are become narrowed. स्मॉल एयरवे नैरो हो जाती है, सिकुड़ी हुई, बिकॉज ऑफ इंटेस्टाइनल फ्लूइड एंड ब्रोंकियल ऑब्स्ट्रक्शन. स्मॉल एयरवे नैरो हो जाती है फ्लूइड एंड ब्रोंकियल ऑब्स्ट्रक्शन के कारण. लंग्स कॉम्प्लिकेशन बिकम मार्केडली डिक्रीज्ड स्टिफ लंग and the result is a characteristic decrease in functional residual capacity and severe hypoxemia. The blood returning to the lung for gas exchange is pumped through the non-ventilated, non-functioning area of the lungs, causing shunting. So the gas exchange is markedly impaired, resulting in severe refractory hypoxemia. Clinical manifestation: fatigue, headache, air hunger, tachycardia, confusion, lethargy, diaphoresis, severe dyspnea. Diagnostic evaluation: physical examination, intercostals retraction and crackle as the fluid begins to leak into the alveolar intestinal space. Chest X-ray: the findings are those seen with cardiogenic pulmonary edema and appear as bilateral infiltrate that quickly worsen. Sputum test, HRCT लंग्स ब्लड इन्वेस्टिगेशन. डायग्नोस्टिक एवल्यूशन में हम स्पुटम टेस्ट करवाएंगे, HRCT लंग्स की और ब्लड इन्वेस्टिगेशन. मैनेजमेंट: medical management. The primary focus in the management of ARDS includes identification and treatment of the underlying condition. इसमें हम आइडेंटिफिकेशन करेंगे और ट्रीटमेंट. एग्रेसिव supportive care must be provided to compensate for the severe respiratory dysfunction. The supportive therapy almost always include intubation and mechanical ventilation support. In addition, circulatory support, adequate fluid volume, and nutritional support are important. Supplemental oxygen is used as the patient begins the initial spiral of hypoxemia. As the hypoxemia progresses, intubation and mechanical ventilation are instituted. The concentration of oxygen and ventilator settings and modes are determined by the patient status. वेंटिलेटर सेटिंग और मोड्स हम पेशेंट के स्टेटस पे सेट करेंगे. दिस इज़ मॉनिटर्ड बाय आर्टिलर ब्लड गैस एनालिसिस, पल्स ऑक्सीमेट्री एंड बेडसाइड पल्मोनरी फंक्शनिंग टेस्ट. बेडसाइड हम पल्मोनरी फंक्शन टेस्ट करेंगे, एबीजी आर्टिलर ब्लड गैस चेक करेंगे, पल्स ऑक्सीमीटर SpO2 लेवल चेक करेंगे. PEEP is a critical part of treatment of ARDS. PEEP usually improved oxygenation, but it does not influence the natural history of the syndrome. Use of PEEP help increase functional residual capacity and reverse alveolar collapse by keeping the alveoli open, resulting in improved arterial oxygenation and a reduction in the severity of the ventilation perfusion imbalance. By using PEEP, a lower FiO2 may be required. The goal is a PaO2 greater than 60 mmHg or an oxygen saturation level of greater than 90% at lowest possible FiO2. Systemic hypotension may occur in ARDS as a result in hypovolemia secondary to leakage of fluid into the interstitial space and depressed cardiac output from high level of PEEP therapy. Hypovolemia must be carefully treated with causing further overload. IV crystalloid solution are administered with careful monitoring of pulmonary status. Pharmacologic therapy. Numerous pharmacological treatments are under investigation to stop the cascade of events leading to ARDS. These include human recombinant interleukin 1 receptor antagonist, neutrophil inhibitors, pulmonary specific vasodilator, surfactant replacement therapy, antisepsis agent, antioxidant therapy, and corticosteroid administered late in the course of ARDS. Nutritional therapy, adequate nutritional support in vital in the treatment of ARDS patient. With ARDS required 35 to 45 kcal per kg per day to meet calorie requirement. Internal feeding is the first consideration. However, parenteral nutrition also may be required. Thank you.